doctor, and now I am a lecturer at Faculty of Tropical Medicine, Mahidol University in Thailand, and I am an infectious disease consultant in Hospital for Tropical Diseases and Thai Travel Clinic. So the case that I bring you today is quite interesting, and this is a patient from the Thai Travel Clinic. So the floor is open. If you have any question, you can interrupt me anytime about the question or about the discussions. So do you want me to present the case right now, or do you want me to wait?
Yeah, we'll while these students are just sort of trickling in, I'll also just explain what the format's going to be looking like today. So hi everybody, hi all the MS1s and MS2s that are here today. Thank you for joining us tonight for the Global Health Selection. As Dr. Thundon has already introduced himself, he is a clinical faculty of tropical medicine over at Mahidol University in Thailand. And he's just going to be talking to us about, as he says, the various cases of infectious disease. For all of you who are interested in infectious disease, I think this is going to be a great talk to be at, and also a lot of these faculty are very open to for you to reach out to. So we're really excited to have you all today. The format's going to be like this. We're going to be talking for Dr. Thundon is going to be presenting for about 50 minutes, and then we're going to leave the last 10 minutes for a sort of Q&A discussion. Please feel free to send any questions that you have, either to the chat at large or to me if you have any questions, or to John Filosa as well. He's also leading this session. John, do you have any words that you want to say?
No, I'm just excited to be here. I took the Global Selective last fall, and it was a great time, and you definitely are in for a treat.
Yeah. Lastly, the only last request that we have is during this entire session, if you could just have your camera on, even if you guys are eating dinner, just for Dr. Thundon's presentation. If that's about it, there might be a few more people trickling in, but please feel free to get started.
Okay, I will share my slide.
Sorry, I would like to ask everyone to talk slowly.
Oh, yes.
Are you okay? Because we are not that catch up your speech.
Sorry,
so we can,
sorry, yes.
But it's not nothing problem, but I just asked to speak slowly.
Absolutely.
A little bit. Thank you. But I didn't on my video because I don't know something happened to my video. It looked like an alien, so.
Oh,
sorry.
not a problem. Sorry, my statement about videos was just mainly directed towards our students. So don't worry about that.
All right, thank you.
Yeah, thank you.
Okay. Yeah, thank you, Ajahn Pornpan, for introduction, and thank you, UCLA, for having me in this session. I am happy to do, and so English is not my mother tongue. So if you have any comment or question about my talking, you can interrupt me anytime during my talk. So I have nothing to discuss today. And the topic that I would like to talk today is maybe involved in the three parts. So first is the epidemiology of the tropical infectious disease, particularly dengue fever and malaria. And the next is I will talk about what are the major challenges in tropical infectious disease. And lastly, what are the social determinants that affect the health impact of the tropical infectious disease. So we can learn about this topic throughout the case that I prepare for you. So first of all, what is the tropics and what is the tropical area? The tropics or tropical area is a line in the middle of the earth, and it's roughly in the middle of the globe, which include the equator and involved in the part of the 5 continents. The first is North America, South America, Africa, Asia, and some part of the Australia. Typically, the tropics are warm all the years and consist of wet and dry seasons. And they involve in the rainfall distribute throughout in the years. And amount of the rain can vary greatly from one area of the tropics to another. And the tropics consist of the tropical climate which is specific and suitable for Anopheles. So you have heard that Anopheles is the vector for the important tropical diseases like malaria. So I will begin with the first case. The first case is a Thai male, 38 years old. He is healthy and visiting our clinic. He worked as the UN officer at the South Sudan for 1 year and presented in the Thai travel clinic because he had an acute and differentiated fever for 1 week. He just returned from the South Sudan for vacation and he stayed in the Bangkok for 2 weeks. The history of the vaccination is quite complete. He received the yellow fever vaccine, meningococcal vaccine, cholera 2 years ago. However, he took the doxycycline as malaria prophylaxis irregularly at that time. The physical examination at the emergency room showed the high-grade fever and notably for the toxic appellants. The others are unremarkable. So these symptoms of the patient fit for the fever returning traveler. So what is the importance of the fever in returning traveler? Tourism are the most affected types of the traveler of the fever returning traveler, followed by the visiting friend and relatives, or we call VFR, about 15%. And nearly 50% they travel from the African continent. 1/3 of the travelers need hospitalization. However, the fatality rate is quite low. Half of them made the travel medicine or receive the pre-travel counseling before they travel. This is quite different from Thai traveler because Thai traveler didn't recognize how is it important of the pre-travel advice or meet the doctor before they travel. And what is the etiology of the fever in returning traveler? Of course, the tropical infectious disease is the first rank of the etiology of fever in returning traveler. In these proportions, 1/5 are caused by the malaria, followed by the dengue, enteric fever, and so on. And when we take a look at by the regions, we found that the malaria is the most common in travel from the African continent. So the first challenges for the physician in non-endemic area, you should have high index of suspicious. So you can consider what is the appropriate investigation for malaria. The blood smear is a simple technique that we use because it's a bedside and quite easy and cheap. So the blood smear can make the diagnosis many tropical infectious disease like malaria, any other disease or any other tropical infectious disease that we use this technique to detect it, to detect the tropical infectious disease. Anyone can list the name of the tropical infectious disease that we detected by the blood smear. Let's begin with the infectious fellow from Sirirat Hospital.
Talk to the microphone, please.
Can you list the name, please?
So dengue infection. So you can see a typical lymphocyte.
Yes, a typical lymphocyte. But it's not specific to dengue, right? So because the atypical lymphocyte is maybe you see in the hematologic disease. You guess any organism that you may be seen in the blood smear if the patient presented with the acute and undifferentiated fever?
Maybe trypanosome.
Yes.
So we can see that the parasite in blood smear.
Yes, yes. Trypanosome is one of the list. Okay, babesiosis. You may be familiar because this is a disease from the America, babesiosis. you see like a malaria-like organisms, but it's quite different in some point. Trypanosomiasis, like you said, you may see the parasitic like a H, look like a S shape in the blood smear. Relapsing fever is a spirochete in the blood smear. Filariasis. Filariasis is some nematode that causes elephantiasis in Asia or in Africa. And lastly is Bartonellosis. It's a bacterial infection that maybe you see the gram-negative in the blood smear. So this case, he is a travel fever returning traveler, and we suspected that he might get malaria. So this blood smear we had taken from these patients. So what do you see? Anyone would like to describe this blood smear, please? Thai fellow, please help me. So you see something is abnormal, right? There's something in red blood cell. It looks like a ring form in the red blood cell. And the next field of the blood smear, you see the morphology of infected red blood cell has been changed. Can you guess what it looks like? So this patient, his red blood cell is look like a comet shape, the comet shape. So it's quite specific to the Plasmodium overlay infection. So the first of the, when you see the blood smear, you should see how the shape of the red blood cell has been changed. So it's maybe bigger and the shape look like a comet. So we made the diagnosis is a Plasmodium overlay. So nowadays there is 5 established human malaria, and there are 5 Plasmodium species that cause the disease in human. And one is a zoonotic disease, or we call Plasmodium noci, named Plasmodium noci. The Plasmodium noci is a malaria parasite of the monkey of the Southeast Asia that's transmitted to the human by Anopheles. So more human cases has been reported in the nearly all of the country in the Southeast Asia. And the traveler returning from the Southeast Asia might get infected by name of Plasmodium noci. And what is the factor that distribute to how we get malaria? So first, the area or the country, because this map show the malaria, the risk of getting malaria zone. So it depends on the area, because there's some area such as the sub-Saharan African or Oceania, or look like some Ajahn Pornpan, you raise your hand, right? Do you have any questions?
Yes, thank you.
Ajahn,
not a question, just some interact. At this point, I would like to ask the DCRA medical student, is there anyone has experience about malaria, and which species of malaria that you have the experience?
You guys ever treated the malaria, or you just have any encounter about the patient with malaria before? Can you share any experience to us, please?
I could just briefly speak, I think, for a lot of the MS1s and MS2s in general. A lot of us, I think, have very little experience directly with treating malaria, or like just being in settings where like there are like clinical settings with malaria present. However, like all of us, oh, sorry, I'll speak a little more slowly. Some of us have just completed our infectious disease block. So I think everybody has a general understanding abstractly of malaria, but if anyone has had any direct clinical experiences, feel free to, I see Mira had her hand up very briefly.
Well, I don't have clinical experience in the most traditional sense, but I did get malaria like last year, and I was in sub-Saharan Africa at the time. So I had the falciparum strain, and I got very sick. So yeah, I can talk a little bit about that, but not treating it or anything like that.
So
all right, thank you very much.
You are the patient before? Wow.
Yeah.
So you sick when you travel in Africa or just returning here?
Yeah, I was living there for 2 years, and I got sick while I was there. So
do you remember the treatment?
yeah, I took actually I don't know if I fully remember the name of the treatment. I was taking doxycycline as a prophylaxis, but I wasn't able to pick up my medication in time one time, and so I think I missed a few doses, and that's how I got sick. But
wow.
I don't fully remember the name of the medication that I took. I think it had a Q in the name, but yeah,
Okay.
that's all I can tell you.
What did you
sorry.
do? I mean,
very sorry to hear that you got it. However, I think Dr. Thundon, you talk about prophylaxis, and in some country we didn't recommend prophylaxis because of like a resistance, something like that. I think Dr. Thundon will talk about it in the future, but I am very glad that you get back soon, very completely, right?
Thank you.
Okay, I will continue my talk. So the first factor that determines how we get the malaria is the destination, right? This map show the risk area such as the sub-Saharan area or the Oceania that's our very high risk. And the next is the duration. If you're staying longer, and the risk of the malaria is getting more to compare with the traveler who live shorter. And another factors is we concern is the types and the resistant profiles. So most of the African malaria is the Plasmodium falciparum. Meanwhile, the vivax or Plasmodium vivax is more common in Asia and South America. So if we are aware of the types of the malaria, so we can give the appropriate treatment, because different types of malaria need a different treatment. And the other concern is the drug-resistant malaria, because in the Southeast Asia or some part of the Oceania, that consists of the drug-resistant malaria. So we should think about, or we should concern this point. This is a map. This is a graph that represents the malaria cases in United States. The CDC received about 2,000 reported from the confirmed cases malaria among the persons who tested positive in the United States and in its territories. And nearly 90% cases were the imported cases from the countries in which the malaria is endemic. And Plasmodium falciparum accounted for around 80%, and also increased the proportion of Plasmodium falciparum around 50%. And the number of the malaria cases among the US is increased, particularly US civilians populations. And we saw the relationship between the increase of the case, which is coincide with the increase of the airline flight or the international traveler that taken by the US citizen. But however, in Thailand, the number of the cases of malaria decreased over time, and the vivax or Plasmodium vivax is accounted for around 80% of the total case of malaria. Even the Plasmodium falciparum decreased, the drug-resistant malaria were observed. This map is show the spread of resistant parasite from the Thai-Cambodian border to the other countries that caused some concern among global malaria stakeholders. And this map represents the rapid growing of genetic resistance over the last 10 years. The bottom line to succeed in the malaria ending is surveillance system. So in those days in Thailand, we lack all the effective monitoring systems. So this research turned the paperwork into the electronic system. If we have the electronic system that can help, it will improve the quality of Thailand malaria surveillance system. And the surveillance system will provide the malaria staff with the close to real-time case management, case detection, and outbreak detection. So this feature has led to the improvement of the qualities of the malaria control programs. In the recently, you might have heard that the WHO approved the malaria vaccine, right? So WHO recommend the malaria vaccine in the children who living in the high transmitting area. The difficulty of the malaria vaccine development is the malaria has a multi-stage. This vaccine target is at the pre-electrocytic stage. So they can block the malaria entry to the human cells. So they can inhibit the human clinical illness or clinical manifestations. Even though the efficacy of the vaccine only 40%, it can reduce the mortality rate, particularly in the children who living in endemic area. So WHO just approved this and recommend this vaccine or name RTSS in the children who living in the Africa. In addition, there are several types of the malaria vaccine platform. So one of the platform is a transmission blocking vaccine that now conducting in Thailand. This vaccine aims to interrupt the transmission of the malaria parasite from the infected human to mosquito. This is an ongoing study in Thailand in the collaboration between the VIVAC unit and Oxford unit. This project was funded by the Wellcome Trust. So what do we get from this research? So they have contributed to the down selection of the key candidate of the VIVAC malaria vaccine. And they provide the key vaccine efficacy data for the vaccine candidate for the clinical trial. So we come to the end of the first case. If you have any question before I start the second case, are there any question about the malaria? This is just talk roughly because I just want to make all of you that familiar with the malaria cases and how we made the diagnosis of malaria. The floor is open before I begin with the second case. So do you have any question about this case, or do you have any other topics that you need me to clarify? Thai fellow, do you have any questions?
Dr. Thundon, I was wondering, how did you treat that case from the case number 1?
Oh, yes, we use chloroquine and primaquine because when we treatment malaria, we have to classify which how severity they are, because this patient is uncomplicated malaria. So we treat with chloroquine and primaquine.
So we seen just a little malaria road from your blood smear. Did you confirm it would be a P. ovale, or you just diagnosed by just only peripheral blood smear?
When we treat the treatment malaria depend on the species, right? So generally we use only the morphology for the treatment and for making the diagnosis. And but in this case we confirm the molecular technique that it is a P. ovale.
And one more trick that I would like to highlight here is maybe in the 20 years later, we will have a robot to see the patient and then say P. ovale, P. falciparum. But now, the characteristic of infected red cell is the key to diagnosis of malaria and also the shape or character of parasite in the cell.
Yes, that's a good point, ครับอาจารย์พรพันธ์ because right now we develop the artificial intelligence for the malaria morphology detections. So in the rural area, if they suspected or what types of the malaria, they can snapshot their screen about the computer screen or mobile screen and send for the specialist or send to the computer or AI that can make the diagnosis. Even though the liver biopsy, they can do it. ครับ This is now is ongoing project ครับอาจารย์
I have a brief
Good morning.
question.
May I have some comment?
ครับอาจารย์ ครับอาจารย์ยุพินครับ
My name is Yupin. I'm quite interested in malaria in particular because I used to do the research on malaria with the so-called model in the past. Because this is a very great opportunity that we join, I mean, from UCLA and Thailand. I heard that one of you, Mira, have an experience of malaria in Africa. So I would like to say something that epidemiology of malaria in Southeast Asia and Africa is quite different. And when we say that malaria is one of the top of the tropical infection, it means that it's malaria in Africa. In Africa, it's hyperendemic area of malaria. So most of the cases are children, especially less than 5 years old. And this caused a lot of death in children there. But compared to Thailand or Southeast Asia, we just only endemic. So it means that it's here, but not as many cases as in Africa. So our epidemiology is totally different. So the malaria in Thailand is mainly affect the adult. And we don't have such high burden as Thundon already said. At the moment, we think we are in the Public Health Ministry of Thailand. They have the long-term project called eradication program. So it means that Thailand is now, malaria is not very common as it should be, and as it be. And we are in the eradication program. So this leads to the problem of difficult to diagnose malaria by morphology, like Dr. Thundon showed you. The technician in Southeast Asia, especially in Thailand, we lack of that experience. So at the moment, WHO also recommend that diagnosis of malaria is based on rapid test everywhere in the world. So this is different between malaria in Southeast Asia and Africa. Thank you very much.
ครับ Okay ครับ Thank you. That's a good point ครับ Professor Yupin ครับ Thank you so much. So anyone have any question or any experience to share?
May I introduce Ajahn Yupin? We call teacher Ajahn in Thai. Dr. Yupin or Professor Yupin is like a queen of tropical medicine. This is very lucky for us to have Dr. Yupin.
Like a mom, not a queen now.
A mom or a queen, that's fine.
Thank you very much, Ajahn Pornpan. I just, just have hear that you are talking about malaria. So I'm interested what is news or what happened. So this is why I joined. Thank you very much.
Okay ครับ Okay, so I will continue my talk. I will talk about the second case. So this is quite different from the first case. This patient is a male backpacker from the UK. He visited our clinic before the COVID endemic, and he stayed in Bangkok for 2 weeks. And his plan is for travel around Southeast Asia for 1 month, which is Thailand is the first destination. And his accommodation is the local hotel near the area named Bang Lampu. The Bang Lampu is some spot in the Bangkok that is a crowded community area like this, which is located near the Grand Palace. And he visited our clinic because he had acute fever with myalgia for 3 days, and physical examination show febrile and other unremarkable. And investigation show the white count is quite low and my elevation of the liver functions. And we confirm with the rapid diagnosis test of the dengue and S1 antigen is show positive. So he was diagnosed with the dengue fever. So the epidemiology is important, right? You have learned from the past case that we show that the traveler from the African, you should think about the malaria. But the traveler is staying in Bangkok for a while and visited our clinic with a fever. So this paper, we retrieved the data from our clinic. What is the cause of the fever? Which is the cause of the fever of febrile illness in hospital for tropical diseases for 10 years. And the dengue fever is the most common one. Around 50 or 40% of the cases are dengue, followed by the unidentified around 30%. So this is interesting because if we do the extensive investigation, around 30 to 40%, we don't know yet what is the cause of the fever in acute and undifferentiated fever. And another thing is the co-infection. We found that the co-infection around 10%. So if your patient presentation is not straightforward, you should think about there might be some co-infection like a dengue with the other tropical infectious disease like leptospirosis or the scab typhus or even bacteremia. This bar chart it shows the incident case of the dengue yearly in Thailand, and the number of the cases vary over the time period. Once the epidemic is happened, you will see the bar chart like this. Once the epidemic happened, the immunity in the populations were developed. So consequently, the peak of the incident after the epidemic is quite lower because the immunity of the patient in community were developed. And the age group of the population was changing. In those days, we might familiar that the dengue fever is a case for pediatricians. But right now, as the internist, we might meet or encounter with the patient adult cases with the dengue fever much more than in the past. And during the last 20 years, the population of the dengue is gradually increased, and most of them are the young adult, 25 to 35 ages. And there are several types of the dengue, likewise the malaria. The dengue consists of the serotype 1 to 4, and the predominant serotype was varied over the years. And this map is retrieved from the ARBONET by the CDC. So this is the map show that there were several cases, imported cases of the dengue in the US that reported to the CDC. And after the COVID endemic, the reported cases were declined. This is because the travel restriction. So the travel may be limited the number of the imported cases of the dengue in US. And Aedes aegypti is a vector or mosquito that is a vector for the dengue fever. This map shows the distribution of the Aedes aegypti. Previously, there was the effective elimination program that controlled this vector. So as the Aedes was controlled in urban of the tropical America and South America, so the epidemic of the dengue fever decline or disappear in much distant region that has successfully control of the mosquito vector. However, the distribution clearly distributed throughout the middle of America and South America. This is because some factor, because the global warming or the temperature. So I will discuss how the temperature that affect the mosquito-borne disease. So another challenges for the tropical infectious disease is temperatures. because the vector and parasite might respond strongly and non-linearly to the temperature and therefore to the climate change. And this research they predict by the modeling approach to incorporate the effect of the temperature on the mosquito and parasite and their transmission. And among the tropical pathogens, the malaria has a lower thermal optimum as about 25 degrees Celsius here. Meanwhile, the dengue and Zika virus has the highest thermal optimum. So we expect that the global warming may affect the vector-borne transmissions. This data are supported by this research. So there are the direct effect of the warming temperature that promote the greater suitability for dengue and reduce the suitability of the malaria transmission by Anopheles. This paper highlights the AD as dengue and dengue as a potential of the emerging public health threat in sub-Saharan Africa. So the map shows the malaria hotspot may be shifted to the East Africa only. Meanwhile, the dengue hotspot may be expanded throughout the sub-Saharan Africa in the future. This is because the high temperature increase or the global warming effect. And however, besides the climate change, there's some urbanization, deforestation that maybe affects the mosquito-borne disease. For instance, Japanese encephalitis. The Japanese encephalitis, have you ever experienced about this case or any patient who concerned about Japanese encephalitis before? Anyone would like to share? Because this is Japanese encephalitis is quite common in Asia. So the Thai fellow, do you have any experience about encephalitis? Many cases of encephalitis, right? Do you have any confirmed cases of JE or any patient who concerned about this case, about this disease?
We have many experience of the encephalitis, but most of them are autoimmune disease or paraneoplastic syndrome related. But for about the JE encephalitis, we didn't have any experience before.
Okay. By theory, they said that this encephalitis is most common one in the Asia. But we never experienced because maybe under diagnosis. So JE is a transmission to human by the Culex mosquito, and transmission principally occur in the rural area. By theory, it occur in the rural area and often associates with the cultivation or the flood irrigation maybe. And the transmission is seasonal. And human disease usually occur peaks in the summer and falls. So let's get back to several factors that interfere or change the transmission of the JE, like changing in agriculture practice or the urban growth and some change of the behavioral of the travelers. So in our clinic, we most of the travelers from international quite concerned a lot about the JE because the several cases reported in literature, they show that the Thailand is one of the top destination in the case reports of the JE. So in my experience, JE is a popular vaccine for the traveler because it is this disease is fatal and we have a vaccine that preventable. It is a vaccine preventable diseases. So the JE virus is most common encephalitis in Asia and occur throughout the country in the Asia and some part of the Pacific area. And in Thailand, it is widespread and occur years round with the peak season in May and October. And there are several cases reported from the northern part of Thailand and southern part of the Thailand. So we come to the end of my talk. I would like to summarize the topic of the topics that we have discussed along the case. So first is the epidemiology of tropical infectious disease. We know that if we know the epidemiology, such as what is the most common cause of the fever in fever returning traveler, and what is the cause of acute febrile illness in hospital for tropical disease in Bangkok, so we can make the diagnosis easier and make the right decision of the treatment. So that's why the epidemiology of tropical infectious disease is important. And when we make the right diagnosis, we can make the right treatment. So another point is the epidemiology of the malaria. You will see that in different destinations, they has different types of the malaria and different treatment. So if we make the correct species of this malaria, we can give the appropriate treatment. And what are the challenges in tropical infectious disease? So if you are, first is recognition. If you are in non-endemic area and you're working in a non-endemic area, you should have high index or suspicious. It does matter. It does matter because if you not suspect that you don't perform the right test, so you maybe miss the diagnosis. And some tropical infectious disease it is difficult to make the diagnosis, like a lichteriosis. The next challenge is the surveillance system. You should, in the country that have a good surveillance system, the ending this disease is more easier. And several factors such as the global warming, climate change, urbanization, or deforestation. This factor is our business to do because the factor determine the tropical infectious disease and maybe affect the mosquito-borne diseases as well. And lastly, the social determinant affect the tropical infectious disease. Like I show in this picture, they work this kind of worker. They work in the gold mining, and in the southern part of the Thailand, they work at the tapping pala rubber. So, Thai fellow, would you give your opinion that why that two of these occupation they have the high risk of any tropical infectious disease? The worker in the gold mining and the worker in the tapping pala rubber in the southern part of the Thailand. Any tropical infectious disease that high risk too?
Okay. Oh, I think the para rubber, it should be growth in the very high humidity area, especially in the southern part of Thailand. So yes, one is the most common is a mosquito-borne disease like a chikungunya, and sometimes dengue infection.
Right.
And
any other mosquito?
Except from the mosquito-borne rickettsiosis, maybe rickettsiosis also. But
okay,
for the gold mine, anyone can.
It's the same.
Is it the same? It's a high humidity.
No. I mean that these two kinds of occupation is high risk exposed to the malaria because they're working out is the same period as the Anopheles feeding activities. So the Anopheles is feeding activity in early morning or at dusk and dawn. So they work during period at this time. So they may have exposed to the Anopheles. So the malaria has if you search the literature review, the gold mining has one occupational that had a high chance of getting malaria. So these are the social determinants that maybe affect the tropical infectious disease. And we have several cases interesting in our clinic, and so we should get interesting case published. in the Tropical Infectious Disease Journal. And this our website. You can visit our website. We are provide some useful article for international traveler, and also the price of the vaccine here is quite cheap. If you can compare this price of the vaccine to other clinics. Not for advertisement, just mention. And
you can advertise your institute too, no problem.
Oh, okay.
But back to the Malaria farmer. I think snake bite is a topical medicine. One of topical medicine. Snake bite is like a neglected topical medicine, right? Am I right?
Yes, yeah. ครับอาจารย์ Thank you your point. That's a good point because some snake bite maybe cause interfere affect our system like a hematologic system or neurologic system. So this kind of worker maybe have a high risk for the snake bites. ครับ And and our faculty serves international students for 10 international program, and we also welcome all of you guys here, even you are the doctor or healthcare personnel or visiting professor. ครับ So thank you for your attention. I think I will take a lot of time today, and I'm happy to take your question. If you have any question, I'm happy. Please.
Wonderful. Thank you so much, Dr. Thundon, for just sharing your presentation with us. If anyone wants to ask any questions, please feel free to unmute your mics.
We have the question from อาจารย์ Nasikan ครับ Professor Nasikan ครับ Do you have any question or any suggestions?
Thank you, Dr. Okay.
Dr. Nasikan is a princess. We have princess already, and this is a princess.
I am a baby. I am a baby.
No, you are a prince.
Okay, thank you, Dr. Thundon, for the great lecture. I just would like to comment about the second case because when the patient come in the first few days, sometimes it's difficult to differentiate between any tropical diseases that cause acute febrile illness. So sometimes you have to use the clinical criteria or the clinical presentation, the predominant clinical presentation of each disease, such as when patients come in with fever and they have disabling joint pain, you can think of the chikungunya. But when the patient come in with acute febrile illness and sometimes have the leukopenia or like GI symptoms like nausea, vomit, you can think of the dengue. Or when patient come in with just low grade fever and rash, you can think of the Zika virus because the three diseases actually transmitted by the same mosquito, and actually three diseases circulated in Thailand and at the same time because after like a raining or because it humid all the year. It's just a practical point. Thank you.
Thank you ครับอาจารย์ So the importance of the clinical clue is important. I think because if we suspect any disease, you should find out what is a specific physical examination, and any hint, any clue from the clinical is important rather than laboratory, because it maybe help us for make the right diagnosis ครับ
I think Dr. Pinyo raised her hand.
อาจารย์พินโยครับ โอเคครับ Over to you ครับอาจารย์
I have one question. Dr. Thundon, can you discuss more about cross-reactivity between dengue serology and COVID-19 serology?
ครับอาจารย์ So in the previous literature, there may be some literature show that the severity and the serology and severity, the two point, serology and severity, that may be cause reaction between the dengue and COVID-19. So you may have heard that in the review literature, there may be cases that report with the dengue fall positive with the COVID-19, and also severity. If in the previous literature, they show about some who infected with the dengue before, they might have a higher severity of the COVID-19.
So the false positive test may be found in dengue, IgG and IgM test, right? But
yes.
not in PCR or NS1.
Yes, because NS1 is non-structural protein for dengue flavivirus. It may be caused with other flavivirus.
So I would like to hear some comments or any question from UCLA, please.
Thank you so much, Dr. Thundon. I will facilitate some of the questions. If someone would like to speak, just please raise your hand and I'll just lead you in. But the first question that I have from the students is just generally with the temperature-dependent mosquitoes that you were talking about earlier. Given that climate changes bring warmer temperatures north, suitable for vectors carrying Zika and dengue, do you believe that there might be an increase in these diseases in the upcoming several years or decades?
I believe so, because this is, except during the COVID, I think after the COVID has subsided, the incident of the true incident of this mosquito-borne disease might be increased. But I think during the COVID, I think they may affect the true epidemiology of mosquito-borne disease at these patients. But you have to wait and see in the next couple of years, the true epidemic may be shown. I think this is my personal.
Wonderful. We love to hear from an expert.
No, I just I'm not too expert, but I a little bit.
Perfect. I believe John has a question that he has in the chat. John, do you want to go ahead?
Sure. I was a little curious about the actions that countries like Thailand have taken to reduce mosquito populations.
You mean the elimination programs?
Yes.
We have yes, the Ministry of Public Health, we have a campaigns, or we have a elimination program of the Aedes or even though Anopheles right now for monitoring the disease and control the vector. Yes, we have by the Ministry of Public Health.
What sorts of actions does the ministry take to reduce the mosquito populations?
Yes, for example, by changing some behavior of the Thai population, like we have to eliminate the water. This is the water. Some water is a environment, is a good environment for the mosquito. So we have to control this factor. Like a fresh water in our house, like in the jar or in something that we have to eliminate them.
Hello, Dr. Nasikan.
Over to you.
Actually, the Aedes can get if you would like to get rid of the Aedes. Actually, we have the several ways to do that, such as the environmental control. Like you have to get rid every still water in the house, because actually Aedes is a peridomestic mosquito. They live close to the human, so you have to get rid of the water that actually open, and we can use the mosquito the larvicidal agents like a cyanide, or you can use the spray attack the adult mosquito, like the spray or DEET. So we have the several ways to get rid of the Aedes mosquito, since the larva, the pupae, and also the mosquito, adult mosquito.
Thank you ครับอาจารย์ณัฐการ
From my opinion, it's very hard to get rid of that because everywhere in Thailand we have like a small water lock, like in every house, everywhere, even in the office. And also tropical is mean hot and humid. So in our country, the water is never been an ice like in winter, like in America. So it has to be changed about lifestyle of Thai people too.
I think the lifestyle and the culture maybe affect the epidemiology and that why we cannot eliminate this tropical infectious disease ครับ I support your idea ครับ Thank you อาจารย์พรพันธ์ครับ
Many people may wonder about crab. Crab is mean sir. Thai man will end of the sentence with crab. That means sir. It's very polite.
Do any of the MS1s or MS2s have any additional questions as well that they would like to bring up? I can go ahead with another one as well. Something I think we talk about a lot here in the United States right now is just the vaccination campaign for COVID-19 in particular. But you were mentioning the COVID campaign, I'm sorry, the vaccination campaign for malaria. How has that been going over in Thailand? And do you face any sort of public resistance towards just general vaccinations in general?
You mean the anti-vax population in Thailand?
Yeah. Yes. Is that any does that present itself as a social barrier?
Actually, in my experience, I think the Thai people about the anti-vax is not common or is quite rare. But even though I have seen one cases with the COVID infection who refused to take any vaccination in COVID-19 just because they're waiting for the mRNA vaccine or effective vaccine, but they do not refuse for any of those kind of vaccine. Just they wait for the good vaccine for them. The good that that the good vaccine is in their personal that they think is good, but they don't know that the vaccine can prevent the death or even the severity of the cases. But they don't know what exactly is. So they think that there is might. They're just waiting for the good one. But about the anti-vax, I never experienced. But I think most of the Thai people, they just comply with the vaccination programs. Right, quite different from your guy, right?
Yeah, we've definitely had our challenges.
I have seen the news that show many anti-vax in US, even though some advertisement that represent that you don't have to get a vaccine, something like that.
Yeah, there's been a lot of not only I think misinformation in the United States, as a lot of students and faculty will attest to here.
Mm-hmm.
But yeah, just a lot of just reticence, as you've been mentioning. So yeah, I think John or Rohini, do either of you? It seems like what?
Yeah, I have a question. Thank you so much, Dr. Thon, for your presentation. It was really great. Mine is a simpler question. So I'm a second-year medical student. We, like Colin mentioned, have just finished our infectious diseases block. One of the things that we talk about, like here in the United States, a lot of the tropical illnesses are less common. So when we go to other countries, it's encouraged that we take medications prophylactically. So I was curious for diseases that are endemic to Thailand, like what does that look like? Do people take medications prophylactically, or is it when you get it, you take it? I was just curious about that. Thank you.
Okay, that's a good question. In Thailand, generally we don't recommend for the taking malaria prophylaxis in Thailand because the incident and attack rate in Thailand is quite low. Even though you stay in Thailand for a while, except you have education for some scientists that working in the deep jungle in the Thai border, that exceptional one. But generally, we do not recommend. This is quite different from the CDC recommendation because in the CDC they recommend for the taking malaria prophylaxis, even though in Thailand. But our data is quite different because the attack rate in Thailand is not high as Africa continent. So you generally don't need to take the malaria prophylaxis in Thailand, or even though any medication for prophylaxis. But I recommend for vaccination, like Japanese encephalitis. If you stay for a long period in Thailand, like 2 weeks, or you stay in the Southeast Asia for a while, I recommend the JE vaccination.
And then a follow-up question, is the JE vaccination a childhood vaccination, or when do people usually get that?
Sorry, repeat your question again, please.
Sure. For the Japanese encephalitis vaccine, is that a childhood vaccine, or do people?
No, I mean in adult, you need to boost is one shot. It depends because the vaccination of JE vaccine in your country is quite different from me because you have the inactivated JE which needed 2 shots, 2 jab. But in our country, we have a live vaccination, so 1 jab is enough. So it's quite different. If you got the first shot in your country, you cannot complete your course of the vaccine here because the inactivated vaccine in our country is not available. But however, we have a live vaccine, so you can continue with the live vaccine here. But for your benefit, you should complete the course of the vaccination before you visit our country.
Thank you so much for your presentation and for answering.
Thank you, your question.
Thank you.
Wonderful, wonderful. In terms of we want to be respectful of your time, Dr. Thundon. Thank you so much for your presentation and just speaking with all of our students here. I know that some of us are fortunate enough to be able to rotate over at your university during our 4th year rotations. If you wouldn't mind, some of our students are very excited to also be able to contact you. Would it be okay for us to allow them to have your email?
Oh, sure.
Yeah, wonderful, wonderful. And thank you so much again for presenting to us so early in the morning, as Rohini says in the chat right there.
We are the early morning person.
That's great. I'm trying to be a little more early morning person, so trying to take after you guys. Thank you everyone so much for coming. I will stay on the line just in case there's any more questions, but I want to make sure that that they're able to do what is on their schedule over in Thailand. So I will send them emails, and thank you again so much, everybody. Oh, there it is in the chat.
Thank you all so much.
Thank you. Before we close this, can you please feedback about the conference like this? Because I work with